Pleasure to join you all today from the 45th anniversary of Charing Cross in London to discuss a truly novel and potentially groundbreaking treatment strategy for patients with small infrarenal abdominal aortic aneurysms. My name is Dr. Michael Jaff. I'm a vascular medicine specialist in Boston. I'm joined by three illustrious, renowned panelists to help uncover this discussion. Joined by Professor Andrew Holden, Professor Ramon Varcoe, and Professor Stephen Cheng. And I'm going to start right away with Ramon. Dr. Varcoe, great to be with you. Tell us, what's the current management strategy for patients with small 3.5 to 5 centimeter infrarenal abdominal aortic aneurysms?
Well, it's pretty straightforward, Michael. I think we've all got several of these patients under our care, dozens in some cases. And what we do is we keep them under active surveillance. And what that means in practical terms is bringing them back periodically for some form of imaging, whether it be duplex ultrasound or CT angiogram, depending on the body habitus generally, and individual patient factors. And we do this repeatedly at intervals of from 12 to 6 months, depending on the size of their aneurysms. As they get larger, closer to that treatment threshold phase, then we start to increase the frequency of those visits.
And what about the medical management of those patients while they're undergoing surveillance? How important is that for their aneurysm specifically?
Well, I think the number one thing in these patients and their medical management is encouraging them to give up smoking. And that's often easier said than done, as we all know. But it's the number one thing we can do in terms of preventing their aneurysm from continuing to grow and reducing their risk of rupture down the track. Blood pressure management is also important, but smoking cessation is number 1, 2, and 3.
Perfect. Dr. Cheng, thanks for joining us today. So you've had experience with the Nectero EAST system, a very novel approach to treat and then prevent small aneurysms from becoming larger and potentially needing an intervention. Tell us a little bit about the Nectero EAST system.
Right. So this is a novel delivery system with the goal to deliver a compound called PGG into the wall of the aorta, and the compound will diffuse into the aortic wall and bind with the connective tissue elastin, fibers, and stabilize or prevent the growth of aortic aneurysms. So the system, or the aneurysm stabilizing system, consisted of a dual balloon system, which is introduced into a patient through a standard femoral artery puncture. It could be done under general anesthesia or local anesthesia as a day procedure. And the catheter has a aortic occlusion balloon, where you will inflate the balloon to control the pressure in the aneurysm sac. And then there is a second stabilizer balloon, which is designed to deliver a fixed amount of PGG solution into the aortic wall within 3 minutes under a set pressure. So the entire system could be done very easily using standard tools, normal endovascular setup with no specialized skills involved.
Great, thank you. And how long do these procedures take in general?
Normally, it would be done in between 30 minutes to under an hour.
Wow. Dr. Holden, great to see you. Thanks for joining us. So I understand that there's been some first-in-human work done. And as you know, from having done a lot of first-in-human work, safety is the most important thing. Is the procedure and the drug safe? But if there are signs of efficacy, interesting to hear. So what have we learned from the initial experience?
Yeah, thanks, Michael. Well, there's been 21 patients that we can report to date that have been treated with this technology. And the two things, as you rightly say, are safety, and that's measured by a 30-day serious adverse event rate. And in terms of technical success, we've also measured that. That's really a procedural outcome. Could you take the EAST catheter system into the patient, deliver the PGG into via the stabilizer or weeping balloon to the aneurysm itself, and then remove the device? So we can say that there was 100% technical success. In all of these patients, we were able to deliver the drug to the aneurysm wall successfully. In terms of safety, there were no serious adverse events out to 30 days. And there were, interestingly, 4 patients who had a transient rise in their liver function tests, AST and ALT. Not totally unexpected, because PGG is metabolized by the liver And so we may see this transient rise, which was entirely asymptomatic and resolves completely. As you know, as you mentioned, we often also look for an early efficacy sign. Essentially, can we reduce the rate of aneurysm growth from what we would predict normally, either in terms of diameter, and on average we'd expect aneurysms to grow by 5 millimeters per year, or volume by 10% per year. What we've seen, and actually Stephen's done the first cases, so has the longest follow-up, but now we've got quite a cohort now that have been followed to 6 and 12 months. And we can see that the rate of aneurysm growth is not only below the predicted rate of growth, it's well below a 50% reduction in the predicted rate of growth. Why is that important? Is because we have good data that if we can reduce the rate of growth of aneurysms by 50%, we can prolong that time that the patients reach a threshold that they need to be treated by 10 years. That'll often take patients, given the average diagnosis age is in the 70s, may mean that they never need treatment, either open surgical or endovascular. So very encouraging early results.
Professor Cheng, as Dr. Holden said, you have the longest follow-up, I believe, to 3 years. Tell us about that patient. What's happened to that aneurysm?
Oh, so that was the first patient that we enrolled 3 years ago. So I recall, if I recall correctly, there was some growth, but not to the point of the expected 5 millimeter per year. So the idea is we can slow the growth of the aneurysm to, say, by 50%, then we can increase the time interval for this particular patient to require a repair of the aneurysm. So that would be the goal. And in many of these patients who are old and have comorbidities, he may never require a repair in his lifetime.
Mm.
And so, Dr. Holden, what's the next step? Is there a larger trial planned?
Yeah, there is a phase 2-3 prospective randomized control trial planned in the US and some other centers, including Australia and New Zealand, where patients will be randomized to either current practice, which is purely observation, versus treatment with this system. So it's going to be an important pivotal trial commencing, I believe, in around Q3 of this year, so not too far away.
Very exciting. And Professor Varcoe, your perspective, if this were to work in this randomized trial, what impact do you think this could have on patients?
I think honestly, Michael, this could be a real game changer. There's several problems with the active surveillance program. You know, you never know how fast these aneurysms will grow from one 12-month period to the next. So that's always a concern. We've all had patients with small aneurysms that have ruptured. It's a rare event, but it does happen, and we feel terrible when it does. And also, I think we underestimate the toll it takes mentally on patients living with this sword of Damocles hanging over their head, just waiting for a time when it might rupture. I've started to appreciate that more and more as I've talked to people about the Nectero EAST system.
Well, as the old person on this panel, I can say that I really don't remember a potential therapeutic like this that could really alter the natural history of a disease condition like this small aneurysm patient population, in which, as you've all said, all we have is watch and wait. So thank you for joining me today.
Thanks, Michael.
Thank you.